So the name of this series is AI in Healthcare webinar series, but we've been mostly concentrating in 2025 in the realm of hematology. Maybe we will expand in 2026. I'm very honored to be co-hosting this webinar series with my friend and colleague, as well as a world expert in the field of AI in healthcare, Dr. Aziz Mizhar. And this series has always been under the umbrella of the Saudi Society of Bone Marrow Transplantation. And tonight's event is sponsored by Bristol Myers Squibb, who we thank for their commitment for education in Saudi Arabia as well. So tonight we're going to be tackling a subject that usually we try to avoid. I remember during our fellowship, MDS is the subject that you usually drop the reading from it. And whenever you're trying to study for exams, it's the one that you always skip. And when you go to ASH, you probably always skip unless you are specialized in MDS. So in such a subject that's very complex, let's see if our traditional approach makes more sense, or if AI will have an impact to make MDS a much more understandable and easier to approach a disease in the future. Tonight, we're going to be having two distinguished speakers. I'm going to be presenting the first one, and then Dr. Aziz will present Dr. David Swoboda. Our first speaker of the night is Dr. Omar Raslan. Actually, he's a friend and a colleague. He worked with us at the Princess Noura Oncology Center in Jeddah, and he's a professor of hematology at the University of Jeddah here. He also has a special interest in the realm of MDS. He has been trained in Canada and currently serves as consultant of hematology at As-Salama Private Hospital in Jeddah as well. And finally, he's my paddle buddy as well, so that makes it special. So Omar is going to be talking to us tonight about MDS from a clinical point of view, starting from diagnosis, prognostication, as well as a quick overview of approach to therapy. Omar, the floor is yours.
Thank you for your kind introduction, Dr. Absi. Thank you, everyone, organizers, SSBMT, and all the others for including me in today's presentation. Just a disclaimer, MDS is not as fun as paddle, so we're going to have to just sit tight and go through the presentation. Hopefully, I'll make it more approachable and more easy to digest. So without further ado, I'll start talking about the status of MDS diagnosis, classification, prognostication, response assessment. Really, the realm of MDS has become more complex given the progressive evolution of genetics and molecular situation and the molecular stratification in the disease. With the addition of new classification systems such as the WHO, the ICC classification, as well as the ELN for MDS/AML overlap. So it can easily become confusing and cumbersome, but I'm here to try to kind of give an overlay of those updates and give kind of a pre-presentation prior to Dr. Swoboda's talk. So regarding the definition of MDS, myelodysplastic syndrome or neoplasms, as is now mentioned, is simply a disease of ineffective hematopoiesis caused by clonal mutations that results in two major things, which are cytopenias and variable risk of transformation to AML. On the right side here are just selected examples from the ASH library showing that MDS is mainly dysplasia or abnormal cell morphology or shapes or sizes, or the keyword nuclear cytoplasmic asynchrony. It needs a trained eye knowing what the normal is prior to understanding what the abnormal is. To diagnose MDS, we need two main criteria. First of all, we need to have cytopenias, then one or more of the following specifications or prerequisites. which is a dysplasia in one or more lineage defined by 10% or more in that cell line, or having a blast percentage 5% or more, or defining genetic alterations such as TP53 mutations being biallelic or multi-hit, or isolated del5q or SF3B1 mutation to define or diagnose MDS. And I want to highlight now and further on in this presentation is, as the name implies, myelodysplasia, we do not require dysplasia to diagnose MDS, as mentioned in the slides here. For classification, there are two main classification systems currently in play or in action: the WHO 2022 classification and the new emerging First International Consensus classification, or the ICC 2022, which is also a different classification system. This Sankey diagram just shows how the old WHO 2016 categories transition into the updated WHO 2022, as well as the ICC 2022. The messy ring sideroblast and multilineage dysplasia labels collapse into cleaner groups such as the SF3B1 mutant or IB1, IB2. It's becoming more neat due to the major shifts in new genetic or mutational discoveries. For the differences, the major differences, I will not speak in too much detail now because I'm presenting them in detail in future slides, but the main differences between ICC and WHO is that the WHO has changed the nomenclature of MDS from being myelodysplastic syndromes into myelodysplastic neoplasms. ICC retained that nomenclature. The number of lineage of dysplasia, such as single lineage or multi-lineage dysplasia, has been removed or dispersed from the WHO classification. There are different nomenclature in the morphologically defined categories. In the ICC, there's a category of MDS AML overlap. With regards to the genetically defined categories, now that's a distinct categories, and this supersedes the morphologically defined ones, as I will be mentioning in a bit. Starting with the WHO category. So as I mentioned, the syndrome has now been classified as a neoplasm. The old classification now has a new genetic and morphologically defined classifications. The excess blast 1, excess blast 2 has changed into increased blast 1, increased blast 2 as just a name, but it retains the same blast percentage counts. There's new mutated TP53 categories, and there are two new modifiers that you can think about them as suffixes to the categories of MDS, such as MDS with fibrosis or hypoplasia. This is a trip into my mind, just a mind map of the MDS, and I know this is as much simplified as I can make it, or kind of a roadmap as simple as it gets for the WHO. So we start off with one or more cytopenias. Then we can look at the blast percentages. So if the blast percentage was 10% or more, right off the bat, this is MDS IB2, but less than 20%, of course. 5 to 9%, meaning that this is MDS IB1. If the blast percentage was less than 5%, we need to make sure that we have dysplasia of 10% or more to call it MDS low blasts. If the cellularity, the bone marrow, was less than 25%, then this would be called MDS low blasts with hypoplasia by definition. Now, talking about the morphologically defined categories, I'm keeping in mind that we are excluding those defining cytogenetic categories, such as del5q or SF3B1 mutations. Then those will be classified as MDS5q and SF3B1 respectively, meaning that those diagnoses will supersede the ones here. And I will describe that in a bit. If the patient has biallelic TP53 mutation, then this is called MDS with biallelic TP53, superseding all the other categories. So the red circles supersedes other categories, and the blue circles here are modifiers that can be added as suffixes to the MDS diagnosis. What about the post-therapy MDS, or therapy-related MDS, as we used to call it? Now it's called MNPCT, for myeloid neoplasm post-cytotoxic therapy. And for ring sideroblast, if it was present 15% or more with the SF3B1 mutation, then this is called MDS SF3B1. Without the SF3B1 mutation, it is still categorized as MDS low blasts with a suffix of ring sideroblasts. The hierarchy that I kept mentioning 2 slides ago was for the biallelic TP53 mutation, which supersedes all other categories of MDS because it has prognostic and therapeutic implications. But blast percentage of 5% or more, putting those in the category of IB1 or IB2 supersedes all the other ones. Then the genetically defined del5Q SF3B1. And if none of these are present, then we can go to the morphologically defined MDS categories. What about having cytopenias with clones and without cytogenetic aberrations that were mentioned before? Clonal cytopenias without dysplasias or without fulfilling the criteria that I previously mentioned in WHO. This will be called CCUS if cytopenias are present. And if we found clones or molecular mutations in the bone marrow without having cytopenias, it would be classified as CHIP. Moving on to the ICC 2022, the ring sideroblast category is now removed. It's not even there anymore. Now it's MDS SF3B1 according to the ICC classification. If the ring sideroblast was present without the SF3B1 mutation, then it's called MDS NOS, unlike the WHO. MDS EB2 is now classified as MDS AML, which is a blast percentage of 10% to 19%. And there are new mutated TP53 categories. Another simplified mind map, and I apologize for the overcomplexion, but that's as simple as I can make it. So starting off with TP53 negative patients, again, we look at the number of cytopenias. If cytopenias are present, we proceed to look at the blast percentage. Blast percentage of 10 to 19%, we can call this MDS AML, unless there was an AML defining mutation, cytogenetics such as core binding factors or certain molecular mutations, then this could be redefined as AML. If the blast percentage was 5 to 9%, then this will be called MDS excess blasts. If not, then we'll be playing in this area here. Make sure that we do not have the defining genetic categories such as del5Q and SF3B1 mutations. If not, then this will be called MDS NOS, whether this is with single lineage dysplasia or multi-lineage dysplasia, or without any dysplasias, just by having those certain cytogenetic abnormalities such as monosomy 7 or deletion 7q and or complex karyotype. What I want to highlight in this slide is that if you notice here, dysplasias are not specific requirements for most of the categories of MDS, meaning that if we have a blast percentage of 10% or 8%, this is MDS EB or MDS AML without even having dysplasia, same as MDS NOS based on the cytogenetic abnormalities. For TP53 mutant patients, the blast percentage, it's a bit more simpler. So that the blast percentage is 10 to 20%, and TP53 mutation of VAF more than 10%, then this is MDS AML with mutated TP53. And if the blast percentage was less than 9%, then this will be also called mutated TP53 if it was multi-hit TP53 or VAF of 10% or more. Again, there is no significance for ring sideroblast in this classification. I'm not talking about the clinical outcomes. I'm talking about significance in the categorization of the disease. They are all now categorized as MDS with SF3B1 mutation. Even if ring sideroblast without SF3B1, it is called MDS NOS. Post-therapy MDS is still called therapy-related MDS as per the ICC classification. Now, moving to the risk stratification, the prognosis varies widely based on multiple factors, either disease biology or the patient's comorbidities or age. So the oldest classification or risk stratification system was the IPSS score in 1997. This is outdated and not really used anymore in this modern age and time. The IPSS-R still is currently used and has not been and is still incorporated. It started incorporating cytogenetics as well. It's still the current standard that we follow in most trials that have been published to date and guiding therapy. IPSS-M has incorporated molecular status Still not widely adopted or adapted, I would say, due to the new and relative classification or risk stratification. It has not yet made it to the trials or whatnot, but it is the future for now. And I will show you the next few slides the divergence between the IPSS-R and IPSS-M and how it can show difference in outcomes or prognostication. For the IPSS-R, mainly these they look at we look at five different categories, one for each cell lineage, neutrophils, platelets, and hemoglobin, one for the blast percentage, and one for cytogenetics. And points are given based on these on the severity of cytopenias, the severity of blast percentage, or the percentage of blasts in the bone marrow, as well as the badness of the cytogenetics per se. The IPSS-R, of course, shows five different classes from very low to very high, which is five different classes in the risk stratification, because these have translated into mortality outcomes as well as risk of transformation to AML. If you see the IPSS scores, after calculating the score, we give a score for each group. The intermediate group here, a lot of the trials or therapies have been categorized as lower risk or higher risk based on a score of 3.5. It's an arbitrary cutoff used in multiple trials or multiple experts, by multiple experts having a cutoff of 3.5, less than 3.5 being lower risk, and above 3.5 being higher risk, for simplification. The IPSS-M has included the same categories of blast percentage, cytopenias, as well as cytogenetics. It has expanded a little bit on cytogenetics, but it also added age and molecular status to its risk stratification. It has given us 6 different risk categories: the very low, low, middle, high, high, and very high. So with more knowledge and more advancements in understanding MDS and incorporating molecular situations or molecular status, it has given us more answers and more diversification in the prognostication of IPSS or of MDS, sorry. So this is the overall survival, leukemia-free survival, and AML transformation risks in all the different IPSS-M, all 6 IPSS-M categories. And as we see here, there is a clear divergence of the curves. This is just a quick exercise that I wanted to present, just to show the differences between IPSS-R and IPSS-M, to hash out the differences and augment what is not seen, or just as an example of what we can be missing as an IPSS-R scoring. So a 70-year-old gentleman with a CBC, as mentioned here, with the hemoglobin, platelet, and ANC counts, bone marrow blast percentage of 8%. Patient has good cytogenetic profile, let's say if it was normal, but they harbor TP53 mutation, a biallelic TP53 mutation. So the two new things here in the IPSS-M is that they're older in age and they have a very high risk mutation. If we apply IPSS-R on this patient, he will be classified, or they will be classified into low risk categories based on the information plugged in the previous slide. But if we apply IPSS-M on this same patient, we will see that it will drop a few categories. Actually, it will be high risk, at least high risk in IPSS-M score, meaning that it translates to worse outcomes across the board in AML transformation and leukemia-free survival. Moving on to out of disease biology, more into the comorbidity scores or the patients themselves, as it does have a huge impact on choosing therapy, whether they go to transplant or not, and even translating it into numbers to explain to patients' prognosis. This is a relatively old scoring system. It has been developed in the IPSS era, I have to say. It has divided patients into 4 comorbidity categories: none, mild, moderate, or severe comorbidities, based on 27 different categories of body systems or comorbidities. And as you see here, independent of other IPSS scores or disease biology, it has translated into overall survival differences in the different categories based on the comorbidities, which is kind of logical. But this is an interesting take here. If you look at the p-values of the lower risk categories, and here when I say low, intermediate, or high, I'm not referring to any IPSS scores. I'm rather referring to applying cytopenia severity as mentioned by this paper. So the degrees of cytopenias, if there was low severity, the differences in outcomes was not very clear between different comorbidity indexes. The outcomes have been different in higher risk categories. To say it again, sorry, the comorbidities have showed difference in outcomes in higher risk categories rather than low risk categories. That's a very huge take from this study with multiple caveats, of course. And another thing, another takeaway from this study is that when they applied this ACE27 comorbidity score to elderly patients above age of 65, the differences were not clear, meaning that older patients are already frail, even if they were fit or, let's say, less morbid or less comorbid. So the two significant conclusions that can be drawn from this: comorbidities had more impact on outcomes in higher risk than low risk patients. The huge caveat here is that the high and low risk based on cytopenias and not molecular mutations or cytogenetics. Comorbidities did not have much impact beyond the age of 65 years old. Finally, I'll talk about the response assessment before I wrap up. So response assessment is divided between the low risk or lower risk MDS, I should say, and higher risk MDS. For the lower risk MDS, we're still applying the 2018 IWG risk stratification. There has not been any updates since then on that realm. So how I think about this, or as mentioned in this beautiful paper, we start by to assess response in the lower risk MDS patients. We start by gathering the baseline assessment requirements, which is screening the patients, determining the transfusion burden classification, determining their hemoglobin, the baseline hemoglobin, and the baseline neutrophils and platelets. 16 weeks of screening is required prior to categorizing these patients into transfusion dependent, non-dependent, low dependency, or high dependency, depending on the number of transfusions required over the 16 weeks period. Quoting the number of transfusions must be on 2 or more different occasions or episodes. For the baseline hemoglobin value, we should calculate the average of all hemoglobin values over a 16-week period. So not just over 4 or 8 weeks. And usually the baseline hemoglobin values are gathered from Q2 weeks or Q3 weeks CBCs. So gathering information and plotting them on a curve is very important to kind of delineate what the real baseline hemoglobin value is. And the baseline platelet and ANC determination document baseline if the baseline was platelet less than 100 or ANC was less than 1. After gathering the baseline information in lower risk MDS patients, we then assess the response. So I like to think about that as the time where the time of the observation. We're holding the stopwatch. We did not click start yet. We're just observing when that response will happen. So once the treatment starts, which is week 0, this is when we start observing for 16 to 24 weeks since starting the therapy. Once the response starts, this is when I call the stopwatch has clicked, or when we monitor the duration of response. What defines response in lower risk MDS in the non-transfusion dependent patients is once hemoglobin hits 1.5 grams per deciliter, or it increases more than 1.5 grams per deciliter, or the date of the next anticipated transfusion has reached without giving the transfusion. Meaning, if a patient requires blood transfusion every 4 weeks, if we reach that 4 weeks mark without getting the transfusion and without requiring a transfusion, this is when we start our timer. This is when we say the patient has started the response, and we start measuring the duration of response after that. Regarding phase 3 is after recording the start of response. If it happened, then we define the success. So for the hematological or the erythroid lineage, in non-transfusion dependent is sustaining that response that we mentioned before for 8 or more weeks. In low transfusion burden, becoming independent from transfusion for 8 or more weeks as well. And the high transfusion burden, also transfusion dependent for 8 or more weeks. But there is a minor criteria, which is 50% or more reduction in RBC units for 8 or more weeks. For platelets, it's either increase of 30 or more, or rise of 100% going from less than 20 to more than 20. Neutrophils, 100% increase, and absolute increase more than 0.5. What about the high-risk category? And I'll be wrapping up after these few slides. We're concluding my presentation after that. For the high-risk categories, we look at the baseline bone marrow blast before assessing response. And I should mention here that the pre-treatment hemoglobin values or the pre-treatment CBCs were not a huge requirement in the high risk, or the new, IWG risk stratification in the 2022 new IWG classification or stratification, except one caveat that I'll mention in the end. But we start with a baseline bone marrow percentage. If it was more than 5%, then we apply this algorithm. So after treatment and with reassessment, if the bone marrow blast became less than 5% and peripheral blood blast 0%, we then look at the hematological parameters. If those were achieved, then in all 3 cell lines, then this is complete response. If less than if one or more cell lines, they're different CR with different lineage response. So bilineage response or unilineage response, but complete response as well. If none of those apply, then we look at the platelet counts. If it did not reach 100%, platelet count of 100 or more, but it did reach 50 or more, or the ANC did not reach 1 or more, but it did reach 0.5 or more, then we call this complete response with incomplete hematological improvement. What about if the bone marrow blast was more than 5% at assessment? We need to make sure if it was not progressive disease, 50% or more in bone marrow blasts, increase in blasts, and the absolute number has increased 5% or more, or it has progressed to AML, then this is called progressive disease. If not, then we look at the hematological categories. If this was achieved, then we call this partial response, given the fact that the bone marrow blast has decreased 50% or more. It might sound a bit confusing, but if you give it one more read, it will be more clarified. But I think the weight here is mainly looking at bone marrow blast percentage reduction and paying attention to hematological parameters responses. If the blast percentage was less than 5% from the get-go, then we look at the hematological responses, and the huge caveat here is we have to have another surrogate marker to look at other than the blast percentage, which is the complete clearance of cytogenetic abnormalities. If this occurred, then this is considered complete response. If not, then we look at hematological improvement applying the IWG 2018 MDS criteria. And then again, the rule applies for MDS as a progression or a progressive disease or a progression to AML. This comes to the conclusion of my presentation. Just to summarize, MDS is, as you saw, is a very heterogeneous group of diseases. It needs vigilant and comprehensive disease assessment. It needs to assess other causes of cytopenias, such as aplastic anemias, PNH, vitamin deficiencies, and whatnot. Fitness assessment, patient values and goals of care and expectations should be assessed, and careful documentation observation needed for accurate response assessment. And as always, reach out to colleagues, read, discuss with others, refer and consult. The world and the globe has become a small town. We're always reaching out to one another, and I will always ask for help from my colleagues. And again, thank you very much for paying attention to my presentation, and I will leave the stage to Dr. David Swoboda. Thank you so much.
Thank you very much, Omar, for the excellent talk. It was amazing to go through a complex topic in very short time. Now, unlike Dr. Absi, David and I love MDS. In fact, we spend our time, all our career in MDS. So it's really great pleasure to kind of transition this excellent talk now to talk about how AI can be applied in myelodysplastic syndrome. And it's really my great pleasure to introduce Dr. Swoboda. So Dr. Swoboda is a great colleague that him and I have been working now for a few years when he was a fellow at Moffitt, and recently we have been working together on the application of AI in MDS. Dr. Swoboda is a hematologist oncologist at Tampa General Hospitals who specializes in malignant hematology. In fact, he's the director of the leukemia program at Tampa General. Prior to joining Tampa General, he was the chief hematology oncology fellow at Lee Moffitt Cancer Center in Tampa. And he also was the chief resident prior to that at Georgetown University Hospital. He completed his medical degree at the Florida State University, and he grew up in Florida, and he stayed in Florida, and he loves Florida. So that's amazing. And David has been doing amazing work, not just in AI, but also the application of genomic and how's that apply in myelodysplastic syndromes. And he has really recent amazing effort to try to bring novel AI technologies to MDS. So I'm very excited to have David and look forward to his talk. David?
Yeah, thank you so much, Aziz. Let me share my slides real quick and then we'll get going. Okay. Okay. You guys should be able to see this okay? Okay. Oh, no, that's not. There we go.
I don't
Yeah.
think we're seeing it.
You guys are seeing it okay?
I don't see the slides.
Of course,
Yeah, it works. It worked before the meeting. It doesn't work
I
during the
know.
meeting.
Yeah, exactly. Let me do it. Try one more time. Let's see.
It looks like it's coming up. Here we go. It's coming up now.
You can't see that? On my end, it's
so give it a second. Now we can. Yeah.
Okay. Yeah. Okay, perfect. Sorry about that. So yeah, thank you so much, Aziz, for the warm introduction. I'm really excited to give this talk. This is actually the first time that I've given this talk. Bear with me a little bit, but I think it's going to be an interesting and exciting talk about some of the existing information in AI and MDS, and really sort of where we are, and most importantly where we're going with AI, as we're in a space of rapid evolving technology and a lot of really exciting things ongoing. And so I'll just first start with my disclosure slide. And then I'm just going to move right into what we're going to be talking about today. So I'm going to start off by talking about some of the machine learning models in MDS, both predictive models, and also some of the ongoing work by Matteo De La Porta looking at digital twins. And then I'm going to focus on generative AI and large language models, and specifically why MDS is sort of the perfect stress test for LLMs. And then finally, I'm going to talk about our virtual tumor board concept. And so why MDS? I think we highlighted it in the last lecture. MDS is complex, and we continue to make it more and more complex, and it really is becoming a very challenging thing for even people that are MDS-based researchers and see this and do this all day, every day, to understand the complexity of the disease. And we also, as you guys know, have an aging population with more patients getting bone marrows, so a much higher prevalence of MDS, and that means more genetic diversity and more patients that really want to understand the how their disease compares to others with myelodysplastic syndrome, and as the prior lecture mentioned, scores therapies are rapidly evolving, and really the nice thing is, because of Dr. Naza and others, AI has been in MDS for now over 10 years. So we have a huge body of work in MDS to build off of in risk prediction and outcome modeling, and now moving into the next generation of AI. And so I wanted to start off just by highlighting a few things of sort of where we've been up to this point. So predominantly, we focused on machine learning and machine learning models and really predictive modeling. And so I just was highlighting four different both diagnostic and prognostic models. The first being a model by the Cliché and others focusing on an AI-based model for flow cytometry. And so what they found here is when adding machine learning, looking at flow cytometry and building a machine learning score on both the validating testing cohort, they achieved around 92% sensitivity and specificity when adding flow in addition to morphologic parameters, and outperformed existing classification systems. And so that just an early application of how we can improve on what we're doing in the diagnosis of MDS. But as we've gotten more genetic information, and now we're dealing not just with DNA but also RNA, gene expression profiling, how do we start better incorporating this into diagnosis? And so another group, Nagata and colleagues, looked just at that, and they used a machine learning model and had over 1,000 patients, and found that we could actually correlate sort of a genomic morphologic signatures. And so what they were able to categorize is distinct genomic morphologic signatures, where we could actually find better association and ultimately improve diagnosis and risk stratification of those subsets of MDS. And I think we see that now in the WHO and ICC guidelines. We really truly have a genomic morphologic phenotype in SF3B1 mutant disease, for example, where they have isolated erythroid dysplasia, or biallelic TP53, where they generally have higher risk disease and increased blast. And so that's kind of set up the stage for that genomic phenomic type classification. But outside of diagnosis, we also have used machine learning and AI for a lot of prognostic modeling. And our own Dr. Naza was actually one of the main leaders in that endeavor. And so he used a random forest model, which looked at clinical and NGS data of around 1,400 MDS patients. They had a training cohort, so they built the model on a training cohort, and then validated it based on multiple external cohorts. And what they found using the modeling is that they were able to greatly outperform IPSS and IPSS-R, looking at overall survival and AML transformation. And I believe, and he also was able to show that they were able to outperform the IPSS-M, which is the most up-to-date prognostic classification that we are now using machine learning and AI. And then finally, I wanted to highlight a more sort of real-world, AI machine learning model which is the AIPSS MDS. And what they actually looked at was registry data. And so they were able to use clinical registry data, build out a machine learning algorithm that ultimately, outperformed IPSS-R and actually approached IPSS-M without mutational data. And they found when they layered in the mutational data, it was, a model that was much better, as you would expect. But they basically recommended this model for centers and areas that might not have access to state-of-the-art mutational sequencing, and found that it was a much better model than our existing platforms. So that's sort of kind of the concept. I could probably have an hour and multiple lectures specifically about the machine learning models that we've looked at in MDS, but that's sort of where we were. But where are we now in MDS and AI? And so to really talk about that, I think I have to highlight the concept of synthetic data and digital twins. And so what are digital twins? What is this concept? And so basically what we're doing is taking a lot of data and ultimately with high resolution models from real world data, being able to simulate, predictive scenarios. And what do I mean by that? So if you think about, you take a large aggregate of patient data, and you can ultimately build out a synthetic model that would be able to do things like predict response to hypomethylating agents, maybe predict who needs a transplant versus not a transplant. And I think the group that has done this the best is the De La Porta group. And so this is their MDS digital twin, or what they call MDS Copilot platform. And so they are aggregating over 30,000 patients with of data. And they actually have this federated distribution model, which allows them to share data without necessarily having to transfer all the data to one centralized site. And now they have able to use this to generate a synthetic model for decision support. So you could give them a case, and then they, based on all the data that they've aggregated, now generate synthetic outcomes for that case if you test them with luspatercept or you test them with Procrit, for example. And then the other big thing that people are really, really excited about is clinical trial optimization. So, unfortunately, in high-risk MDS, we've had tons of trials phase 3 clinical trials that have failed. And so we have a lot of, HMA-based controlled data that's out there and available. And so as we get the FDA to understand sort of this digital twin process, and I think they are slowly buying into the idea, the concept would be, now let's run a phase 3 clinical trial where we have an HMA plus something versus a synthetic control arm, and that would allow us to much more rapidly enroll patients on the clinical study, have all the patients get access to drug rather than continue to give patients hypomethylating agents when we know the outcome of that, and hopefully lead to more drug approvals. And so that's kind of where digital twin technology is going. We highlighted the IPSS-M in the last lecture, so I won't go too much through this slide. IPSS-M is not a machine learning based prognostic scoring system. It really is, advanced biostatistics that ultimately that came up with this classification that put patients in 6 different categories. But for this group, I thought it would be really pertinent to highlight Dr. De La Porta's data on transplant. And so one of the challenges, now that we have no prognostic scoring systems, we have patients that are in this IPSS-R, which is clinical only, right? Prognostic scoring, that are low risk, but IPSS-M, high risk, as was highlighted earlier by Dr. Raslan. So what do we do in regards to transplant for these patients? So the first question they looked at was the IPSS-M and looked at transplant policy. And so basically what they're highlighting here is this is what the overall survival would be in their population cohort. And then this is a synthetic generated a survival based on if you delayed transplant. So as you would expect, the older you get, the worse outcomes overall with MDS. And as you get into a higher risk category, the earlier you do the transplant, so this is a survival on the y-axis, the better the outcome is. As you delay transplant, the worse the outcome ultimately becomes. Different than in low or moderate risk categories, where you actually have worse outcomes if you do an early transplant, and you have a better outcome if you delay transplant further and further in that patient population. And so what about the question that we were just asking, IPSS-R versus IPSS-M? And so about 15% of patients that were high risk went to lower risk category when you transferred over from an IPSS-R to IPSS-M, and about 19 went from a low to high risk category. And what they found when they did their survival modeling is that when you actually focused on an IPSS-M based transplant policy, so basically saying high risk patients based on IPSS-M go to transplant, low risk don't, overall, they had a statistically and very statistically different survival advantage based on their synthetic survival data that they generated. Adding to the additional evidence that says maybe we should use molecular data to support moving into transplant for otherwise higher risk patients. But I thought that was a nice example of how to use synthetic data to generate information that is applicable in real life, everyday practice of an MDS physician and a transplant physician. So that's kind of where we've been, where we are, but where are we now going? And so, I think the goal ultimately in the long term is to move away from predictive modeling, risk scores, survival probabilities, to moving to an era where we can have narrative outputs, plans, true AI-based explanations. And that's where generative AI and large language models come in. So, what is generative AI? I did steal this slide from Aziz and then updated a little bit because I like the slide. So we are generating something from something, right? So we're taking text and, maybe generating a conversation or a question, or we're even translating text or developing a classification. We're generating an image from text. We're generating a video from text. We're generating code, directly. How do I code and having the generative AI or large language models make the code for us? Actually, a lot of the project that I'm going to discuss about, was not necessarily directly coding. It was generative AI based coding that led to what we're doing in our project. You can take image and you can generate image to text. You can take an image and generate an image, or you can even modify an image. And I think there's a lot of broad-based applicability of this, I see, almost all of my colleagues have some experience at least trying and utilizing this. And so I think right now, what is AI and large language models like ChatGPT, Claude, the new Perplexity, and even, really, really gaining a lot of ground, open evidence, which is purposed for specifically medical providers. What are they really doing? Right now, these large language models are taking in massive amounts of data, right, including biomedical content, and they've been proven. They are now passing multiple choice based medical exams, including the USMLE's board exams. And they're very helpful. We can draft notes. We can, let's say dot phrases for Epic. We can do patient templates. This is just a quick, typing in, I'm a malignant hematologist, draft a work letter for a patient. And within seconds, it rapidly gives you something that's really nice for your patients. You can, take, really complex topics and ask large language models like ChatGPT to generate, really nice patient-based educations. And so a lot of things that we can do with LLMs in medicine, but we're sort of just scratching the surface there in using it primarily for administrative tasks and not necessarily clinical tasks. But right now, I would say, we don't necessarily feel like they're clinically trustworthy and clinically safe. And I'll tell you that, that's probably true based on the data that we have. And so what right now are the strengths that we have in large language models? These have a broad medical knowledge. They are rapidly able to synthesize guidelines and literature. They are able to follow multi-step instructions. So we, even use reasoning, which we call chain of thought reasoning. We're to really outline something in a step-by-step fashion, and they're always available. So, unlike the medical student that you ask to research the paper, in this case, you can ask ChatGPT to help you research your paper any time of the day, and there's really no fatigue. But what are the challenges? And so these large language models can generate fake information. We call that hallucinations. And so they can actually give us false statements, give you false references. And that's something that you have to be aware of and know to look out for, and have to ensure that when you prompt to try to avoid these issues. Prompt meaning your input that you put within a large language model. They can provide inconsistent answers. So even if you put an input, right, if you modify that input even slightly, the answer will be slightly different. And so the reproducibility is somewhat challenging. They have no clinical judgment or context awareness. They don't have the physician eye test, as they say. And then there's bias. The biased information goes in, which, ultimately can lead to biased information coming out. So we have to be aware of the weaknesses and ultimately understand, okay, now how do we, make these things better? And so why is MDS the perfect stress test for large language models? I think the last lecture really, really highlighted it well. We are now dealing with two complicated, diagnostic classifications that even as someone that treats MDS and focuses on MDS all day, every day, I feel like my head starts to spin as we walk through these slides, and as we talk to this, with our patients, we're transitioning from an IPSS-R molecular classification to IPSS-M, and IPSS-M is not quick. When you're sitting in your clinic, it can take, multiple minutes just to get back a score on a patient. In a busy clinic, that can sometimes be challenging. And then we have new FDA approvals, and so ultimately the landscape is changing. And so how does LLMs pair well with what we're trying to do in a rapidly changing and extremely complex disease that many of our colleagues try to avoid, as discussed earlier? But why can LLMs help, and why does it fit well with this? Because most of this complex information is actually in a framework that works well with a large language model. It's a guideline. It's a calculation that we can plug and play and do faster with with AI than what a physician would otherwise be able to do with their naked eye or with a calculated model. MDS is obviously complex. Treatment is complex, but ultimately, in comparison to some other disease that might have 16, 17 treatments, it is a little bit more algorithmic in the way that we do that, which might allow us to use, an LLM-based treatment algorithm a little bit better. And, LLMs can follow multi-step prompts and generate explanations that are really, user and physician friendly. But why is general large language models not enough? And so we've looked at this, and this is just a couple studies. There's probably now 10 plus studies basically asking the same question. And the first study is looking at the NCCN and looking at ChatGPT. And basically, they were able to provide one NCCN concordant option in all answers, but a third provided a non-guideline based option, even when you prompted to ask it specifically NCCN. And there was a percentage around 10 to 15% that it generated hallucinated, which is incorrect or inaccurate answers. In breast cancer cases and breast cancer tumor board cases, they used ChatGPT, but it only was about 40% consistent with expert recommendations. And when they did multiple runs, each run was about 30% consistent with the prior run. And then when we looked at heme malignancies, it was about 3 out of 5 on a Likert score, accurate, consistent with what expert recommendations would have recommended for the answer, and got worse as we were looking at newer, rapidly evolving therapies. So overall, general large language models are inconsistent as a standalone decision tool for complex medical cases in our current state. So where do we go from here? So how do we make this better? And so that's where the concept of an AI agent comes in. And so what is an AI agent? You hear it on commercials with Matthew McConaughey, but does anyone actually really know what it is? And so, ultimately, the way that I think about an AI agent is it is a small piece of software. I almost think about it as a sophisticated chatbot. And this piece of software is powered by a large language model on the back end. So we have access to updated information. It can actually pull information off ChatGPT, off Claude, whichever large language model you use. And it is task oriented. So you define a very specific task that you want the agent to perform, and it will ultimately perform that task very well. It has memory, so it has short-term memory, long-term memory. It has internal knowledge, and you can layer in reasoning. So it actually thinks more, better and is a little bit better to understand. And it can understand voice as well. So ultimately, we now have a very task-oriented, specific software that is now individualized for a scenario that you were trying to accomplish. And using just a single AI agent for the same task compared to a general large language model, and a single AI agent outperforms the task. But what if you put multiple agents together? And we've done that, and many others have done that. And actually, if you start creating, multiple AI agents, even with finer defined tasks, you get a much better output. And so that's really the background of what our project is. And so this is our MDS virtual tumor board, or virtual MDS panel. And so the goal is to mimic a real life tumor board using AI agents. And so what did we do here? So we have a physician that is ultimately feeding de-identified patient case information, and it can be extremely unstructured, extremely disorganized. You can copy and paste the worst clinician's note and ultimately drop the information in. And we have an AI agent that's a moderator agent. So what does the moderator agent do? It actually will take the data, it synthesizes the data, it structures the data, and then feeds it to the next agent. So we have this pathology agent that then pulls the WHO and ICC guidelines and will actually reference the guidelines and then provide that information back. And then we have a prognostic agent that really quickly calculates the IPSS-R&M. We have a treatment recommendation that references the NCCN and ESMO guidelines. All of this goes back to the moderator agent that synthesizes all the data, can even cross-check the data, and then spits out a nice, summary of the data to the physician. And it's really nice. It looks, it ultimately is communicating back and forth autonomously and will give information just as if you are using, in a real life tumor board. And so that's sort of the concept. That's the brain and the framework behind what we were trying to do. But now we have to validate it. We have to prove that what we are doing is something that is of interest. And so what we did in our first rendition of this project was we generated 30 complex cases. And when I say complex, I wanted to generate cases that really tested the models. And so we generated patients that might be CMML or CCUS, as was described earlier, or a patient that had a diagnosis of AML or MDS, but maybe based on a molecular signature is actually now based on the WHO AML. And so we had 30 complex cases. We tested it with our virtual MDS panel versus, at the time, the most state-of-the-art large language models, and we used a single prompt. And we had 11 world-renowned international experts, blindly rate the outputs. And so we gave them, which to the bane of their existence, them reviewing, these 6 different outputs from 30 cases. And they, scored on a 1 to 5 Likert scale, which was most consistent and most accurate, or was an accurate response. They flagged any errors, minor and major errors, and they picked the one they liked the most. And so what did we get from the baseline large language model performance in MDS? It was okay, so especially the reasoning models like O3 was around 66% consistent with expert recommendations. The other models were anywhere between 30 to 40% consistent with an expert recommendation. But the challenge is, error. So hallucinations occurred frequently. About a fourth of the cases had, a major error defined by the expert panel when we had these outputs for these complex cases. So what about our virtual MDS panel and multi-agent platform? So, as you can see, the rate of error or hallucinations was much better. So it was about 8%. The overall concordance with an expert opinion was about 90%, highest in diagnosis and prognosis, 83% in treatment. And it was the preferred model to the experts when they were choosing it blindly. And you say, oh well, it's 90%. That's not 100%. You put these same 10, 11 experts in a room and ask them to come up with 100% concordance for anything. It's never going to happen. People are going to argue for days. It's just not a realistic scenario. And so, I'm running a little low on time, so I'll go through these slides quickly. But what was the problem with general large language models? They misclassified, they under-recognized things like biallelic TP53, they hallucinated, and they often overtreated, whereas our model followed the rules and the guidelines much better and provided a much better, output. And so this is sort of what the summary looks like. You provide a clinical case. You get a nice summary of key features, diagnostic, prognostic, and treatment recommendations. All this in about a minute and a half, and it is now a virtual tumor board for complex cases. So you can imagine if you are a busy provider in clinic or a community provider that doesn't see a lot of MDS, how helpful this would be to get all of this information in the matter of a minute or so, rather than, looking at the NCCN guidelines, the WHO guidelines, all of this information that we're trying to give you, and really extract the same information in real time. You just wouldn't do it. Versus now, we can get you guideline-based recommendations in a short period of time using a expert validated AI-based platform. And so what are the limitations of our project? We need to, expand and, and look at prospective real world data. We need to extend it to other diseases, and we need to gain trust, most importantly. And so in summary, I think, Dr. Naza and others have generated a lot of really exciting work in machine learning. Digital twins are, a very interesting concept that I think you're going to hear more and more about. But, in my mind, the next, generation is large language models, and really multi-agent large language models. And so now we just have to better incorporate all these large data sets, that we have into these large language models to really provide the best AI-based personalized recommendations for MDS patients in the future. So with that, I'll turn it over to questions and answers. Thank you so much.
Awesome. Thank you very much, David, for the amazing talk and for the amazing information. I really loved how you moved from the past, the present, and also take us to the future. And that was really amazing. So thank you very much for taking the time. So now we're really at the open discussion for our two speakers. So I really encourage the attendees to ask questions and in the chat, and Ahmed and I will hopefully be able to ask those questions. I'll start first. I think many of us here on the call is trying to kind of understand the evolving landscape of AI, especially now with the new development of all of these tools that David was talking about. And what was interesting, I can tell you, as David, I've been mentoring David. David started, I would say, 24 with a hate relationship of ChatGPT. That relationship evolved to hate and love relationship between January and February. That eventually evolved to love relationship with ChatGPT. So what I want David to share with everybody who's trying to get to this, your journey, how did you start to, honestly, the multi-agent framework that you saw here was developed and coded by David. So he's a hematologist, but now sort of, this is where the opportunity for all of us, the world we live in, that we are able to do those tools even with typing, not even writing a code. So what I would love for David to share with everybody here, because I'm sure there are a lot of students and in the attendees and residents and fellows and faculties. How do you start your journey? How did you start your journey? And if they want to start their journey, what is your advice to them?
Yeah. So thanks, Aziz, for the great question. Yeah, so as Aziz mentioned, when I started, all of my research, up to a couple of years ago was primarily based on molecular data in MDS. And, Aziz really, kept pushing and said, you got to start to focus on, AI. You got, and at the time, like he said, I was someone that was using ChatGPT, to a basic level for some of the functionality that but didn't really fully understand, what large language models, how could we really apply them? And I think the first step, what I would say is, download it on your phone, get at least the plus version, which is the slightly better version, and just use it for everything. And so, this is where the hate will come in, because a lot of times it will generate things, if you don't prompt it correctly, that will not be very good, or will generate things that you say, oh, this is not valid, this is not accurate. And a lot of it has to do with you are not giving it the information it needs to ultimately succeed. So, it's not just a plug and play situation, at least currently. The better the information that you input in, the better information comes out. And so, and the models are getting better. And so even since I started to where we are now, things are way better, things work way better. But yeah, you have to continuously trial and error. And then what you find is as you get better and better, the efficiency of everything that you do gets faster and faster, and you have more time to then play more, and you start becoming an expert in this area. And so now there really is nothing that I do that is not, at least in part, trialed at some point within ChatGPT or another LLM. And then we see what happens. If it's really good, it's good. If it's not, then I move on and try it again in a couple months. But that's really helped me a lot, is just really fully invest the time in using it in everything that I ultimately do. Outside of that, in the multi-agent work, it's having good mentors and people around you, and just be willing to sort of experiment and play and learn, was ultimately how I built the knowledge there. And it's a lot of just time and effort and doing things over and over again, and then you get better and better at it. So but yeah, no, like I said, now everything I do involves large language models. I would say, I'm in the love category, and now every time I talk to anyone, I feel like I'm saying, oh, just use ChatGPT to do this or that, and I think it's a little cliche almost at this point, but yeah, no, that's kind of how I went through it. And definitely, if you have interest, I think it's very doable and very attainable.
Awesome. Thank you, David. I guess we can move to Amal. Amal, you have questions, you raise your hand first, and then we can get the second question. Amal, do you hear us? Not sure if you can maybe say the question.
I don't think they can speak up.
You can
from
just
their
type
access.
it. Got it.
They
You
Yes.
can just type
Yeah,
the
they
question.
just need to type it. Until she
If you
types
type-
it, maybe we can take the question of Dr. Yahya Al-Ghamdi from the chat.
Are you currently using AI models in bone marrow pathology service to diagnose or quantify dysplasia? That's an excellent question.
So at Tampa General, we do have digital pathology. So they are currently using the platform. It's not something that I am using. There's a lot of different digital pathology platforms that are available. And so probably pathologists that are better to speak on it. But we definitely have a tool that our pathologists use. How functional the tool actually is right now, but they're just getting better and better. And again, the goal is not to replace physicians. I think that's the most important thing here. The goal is to augment, improve, and actually make physicians more efficient in the tasks that they already do.
Yeah,
Actually,
I think.
yeah.
Go ahead.
A quick follow-up for that, David. This dilemma in philosophy where, the tree falls in the middle of the forest. So the way I look at bone marrow biopsies and MDS is as such, because you do bone marrows and you detect something that if you've done the bone marrow 6 months later, that would have meant automatically 6 months more of overall survival. And you didn't have to do the bone marrow earlier. The question is, do you think that in the era of AI or the future, would we be still needing bone marrow biopsies and MDS? Would we still be needing morphology, given all the other models that are developing?
Yeah, that's a controversial question. I think the reality, is that with both DNA and RNA sequencing and gene expression profiling and what we're able to get with some of the sophisticated testing that we're even doing with some of the collaborators that we have, I do think morphology is going to be less important. But I don't know if I don't know if we're there to where we can say it's non-existent anymore. But yeah, I think we're getting a lot of information. I think most of what we're doing is molecular-based classification and gene expression profiling-based classification. So I think we're moving in that direction. I would say right now we're not there. Maybe in the next 5 years we will be.
May I add to that, Dr. Absi? I think as we presented in the slides, I mean the dysplasias, as you see in the WHO and ICC, is not actually a prerequisite in most MDS categories. So to that, maybe just detecting molecular mutations or certain defining cytogenetic changes is the mainstay of diagnosis of MDS, and the dysplasias have become the lesser, or actually the least amount of weight to diagnose MDS. So I wouldn't want to say the exception, but it has been shifting, like Dr. Swoboda and yourself have been mentioning, that it has been shifting really away from actually detecting dysplasias. And because sometimes we're overcalling or undercalling dysplasias, and as you mentioned, not doing or having the lead time bias or biopsying 6 months earlier may not show that percentage of dysplasia at that point, but maybe if we do it a year after, it will be full-blown dysplasias in all 3 lines. So yeah, I'm not sure, but the dysplasias are already not that major contributor to diagnosing MDS per se.
Great. The other question from Dina: how does the average non-technical physician developing expertise to build and deploy such AI solutions?
Yeah, like I mentioned earlier, I think non-technical physician. So yeah, like I mentioned earlier, I think you have to start by just understanding, what are the strengths and weaknesses of large language models in general. And really, the only way of doing that is just playing with it in a lot of different ways. To actually get to the expertise to build and deploy, I think the nice thing about code is that people basically share their code, publicly available. And so, there's a lot of sites and videos where you can actually learn things in real time. So you get information, you start with the basics, and then as you sort of test and train, you kind of build on that by just doing, and I think that's the most important thing. You come up with the concept, and then you start, okay, how would I actually do this? And you play around with it, and you get better and better, and you learn by both the successes and the mistakes and errors that come. I know Aziz can really address this because he gives lecture series on specifically this point. So
yeah, thanks, David. So this is it's such an interesting time that we live in now, that there are many things I think we take it for granted, but this is why maybe this is the best time in human history for us to take full advantage of the technology. So let's take ChatGPT, for example. First of all, you have a free access to all of those tools. Yes, if you pay some money, you get
Aziz, we don't hear you anymore.
reality. Have access now to, like, the majority. If you pay $20 for ChatGPT a month, it's still so cheap in terms of the return on investment. So you have really access to these tools that is cheap. The second part, these tools are evolving very quickly in getting smarter, better, and cheaper every day. In fact, even if you look at ChatGPT today compared to 6 months ago, it's like a completely different product in terms of its understanding, the context awareness, the complexity of the task that it can do. And this is probably, for sure it's going to continue. So Ethan Malik said, the AI that you use today is the worst AI you will be using in the future, which means that technology is going to be evolving every day. It's going to get better every day. And there's a lot of opportunity for that technology. And then because of this technology, it's sort of democratizing how do you use it, because now you don't have to code. As David was saying, you could type, for example, a text, and the generative AI, the algorithm, if a lot of apps now, you can just go, I want to build this and this and this, give it instructions, and it will build the app for you. Yes, it's not the perfect app. It's not something you're going to go and sell, for example, but you can do that. I was working on this. I built a project management tool over the weekend. It took me about 2 hours. It's a beautiful project management tool. The things I need to do and move it on. I didn't put any line of code. So recognizing that this is available, I think it's excellent. And then the next stage for everybody, and that's what I keep telling people, use it, but use it in your work. And I think this is the missing point here. A lot of people use ChatGPT to ask it about where should I eat my dinner or how do I cook this. That's fine, but that's not what I'm talking about. Use it in your work. Use it to ask questions in your clinic. Use it to write, insurance letter, like a letter for a patient. Use it in your research to summarize research, put things together. Once you start using it, you will learn the strengths and weaknesses of the model. And then as you're using it more, you get familiar with it and becomes easier for you to use it. But unless you use it, it's going to be really hard to kind of understand all of those things. So that will be my advice. Just start using it in your work. You will learn from it. I mean, now I shifted everything to learn from ChatGPT. So I ask it to teach me something or to write a prompt for me instead of, go and research something, and then makes it easier for me to learn too about any topics I want to learn.
May I ask a question to the group? So
Yeah, go ahead.
as we're talking about AI heavy talk, I will go out a little bit outside of the ballpark of MDS and just talking about AI in general. And Dr. Nazha, you do bring something very important to the table, which is the harnessing AI to use in studies and in writing research or in publications or whatnot. Right now, a lot of there's a lot of regulations around using language models and writing AI script in the manuscript. How do you go about this? I mean, as you mentioned, it's gonna get better to not be detected, and from now it's there are like applications to humanize text and whatnot. I personally would want to hear your take on why would we not be why is it not allowed to use ChatGPT generated text in writing manuscripts, especially if I am reviewing, for example, the data, if I'm proofreading once and twice, making sure the references are okay. I mean, it's a tool. It's like saying to someone, don't publish using Microsoft Word if you have to use a typewriter, for example. So do you have any idea why that is, or any advice from your side? Because I like to publish and write and whatnot, and I'm finding a difficulty in that regard. So I'd like to hear everyone's opinion on this.
Yeah, that's an excellent question. So I feel like sometimes there's logic and there's regulation, right? So the logic will say, yeah, why don't write it there? I mean, it's not like ChatGPT gonna wake up at 4 a.m. decide to write a manuscript on its own, right? So you're gonna give the prompts, you're gonna give the information, you're gonna add the data, you're gonna analyze the data, and ultimately at the end you will be responsible about that data, because as David was saying, there's a hallucination. Even when you do analysis, we have done a lot of analysis with it, it does mistakes. And you're responsible about those mistakes, not ChatGPT, right? So responsibility is yours. From governance, regulatory stuff, I think sometimes what happens, when people don't understand the technology, it's easy to say no. So don't use it, right? So that's the knee-jerk answer. So don't use it in publication. Why? Like, nobody can provide why. Well, if I'm responsible about reading it, if I'm responsible about drafting it, I'm responsible about everything, why cannot use it? It's like asking the same, you said, people use ghostwriters. Why it's okay to use a ghostwriter, not okay to use ChatGPT, right? I think part of it, sometimes people come up with knee-jerk solutions to something that they don't understand. And what happened when you have one or two journals come up with something, everybody sort of follow that regards. And nobody gonna stop and question, nature and science and say, why you guys are not. And I can tell you honestly, they, at this level today, they cannot detect. They don't, detect. So I did an experiment when I was teaching in class. In my class, I encourage people to use it. But in that part, I said, you're not allowed to use it. And then what I did for the students, I said, look, I used the software, which I didn't, to detect, and I thought 90% of you used AI. If you did not use it, you can protest and say, I did not use it. And none of them protested. So I got my answer, right? But I didn't use anything, and they would have fooled me. So it's really hard. So what do I do? What I do is I use it to structure the manuscript, to give me the first lines, and then I tweak it and change it. So the initial draft it gives me, but the final draft, I'm the one who's building it. And this is how I do it. And you know what's interesting, by the way? We just published a paper about AI in hematology in blood. And we generated the images using ChatGPT, and we disclosed that. And if you go to the paper, it says image generated by ChatGPT. And blood accepted that. It wasn't an issue, like, oh, you generated your image with ChatGPT. So I think they are more open now, as long as you also disclose it. So if you think about ASH, you're not allowed to submit an abstract that is AI written, but you can disclose that AI was used in this stuff. So hopefully we will move to that where, as long as you disclose it, which is fine, then it should be okay.
Fair enough.
Let me take you back to the MDS realm. Two questions actually to both, actually to three of you. Number one, what is the most underrated prognostic factor, I would say, that was underrated clinically, but discovered to be more relevant by AI? And then from clinical point of view, from clinical recommendations, pure clinical recommendations, what did AI change in terms of which category would deserve to be taken to transplant earlier? Did it actually make us change those recommendations, or will it make us change those recommendations in any manner?
Silence. So I'm happy to take that question, because that's what we have done when I started the journey on doing the machine learning. So the model that David talked about, the prognostic model, the personalized prediction model that we did, we took clinical data and genomic data. So that was an evolution, by the way. We have the IPSSR. We added 3 mutations on the top of IPSSR using traditional statistics, and we showed that this IPSSR plus those mutation is better than IPSSR. That was even before the IPSSM invention. And when we submitted the paper, they rejected it from JCO and say, you cannot call it IPSSM because the international working group is working on IPSSM. That was in like 2014. and probably somebody reviewed the paper, said, oh, we're working on this for 6-7 years coming. So, but when we showed 3 genes, SF3B1, TP53, and RUNX1, sorry, EZH1, EZH2, that's what get you to IPSSR. But when we build the personalized model, to your question, Ahmed, what did machine learning add? In traditional statistics, you use univariate, and then you take that univariate and put it in multivariate. The problem with that, and by the way, these are issues with the IPSSM, there are some variables, especially in mutations, that can be only significant in the context of other variables. But on their own, they fell out of the univariate analysis, if that makes sense. So especially when you have like genomic data. So what we did with the machine learning, we took all the variables, clinical and mutational data, we put them in the algorithm, and then we build the model to predict survival. And then we asked the algorithm, what are the most important variables that impacted the survival? And then we rank those variables. And what turns out, and this is important, get missed a lot, by the way, cytogenetics is #1 important clinical variables. And you know it, by the way, by the IPSSR and IPSSM. In fact, anybody with complex karyotype, it's automatically high risk, or very complex karyotype. Automatically high risk. Don't look at anything else. They are automatically high risk. #2 is BLAST. And BLAST is #1 for AML progression, which makes sense. So the number of BLAST. And then the clinical variables, hemoglobin platelets. And what we found all the time, clinical variables on the top and mutational data on the bottom. And the only thing important in mutational data, the number of mutations, which is very tricky variable. Because if your panel is 70, my panel is 30 genes, the number of mutations vary. But we showed that the number of mutation has an impact on progression of the disease, progression to acute myeloid leukemia. Then you have the TP53. And this biallelic TP53 doesn't make any sense, by the way. I can tell you why. And we have done that research. But, it's like, you say something and everybody moves with it. So we all move with it. But TP53, we already know that the survival is lower. However, TP53 and the valid allele frequency has an impact on survival. By the way, when we put valid allele frequency, the type of mutation in the survival model, they didn't come up as important for the genomic data. So if you take the IPSSM today, honestly, if you focus on blast and cytogenetics, you're getting 90% of the predictability, and some of the mutation will have an impact. In fact, we did a study, we never published it. Our old IPSSR plus mutation, which we hope to call it IPSSM at that time, performed similar in C index compared to the full IPSSM, which is very difficult to do in the clinic, by the way, because of the multiple mutations and all of those interactions and those things. So I still believe that the clinical variables have the most weight in prognostications. And then the genomic data will add, especially, but in a handful of genes. SF3B1 is positive thing. TP53 is really bad. RUNX1 is bad. EZH2 is bad. And everything else is just play a small impact here and there. I don't know, David, Omar, you...
Yeah, so I think the only other thing that you didn't mention is, I do think right now with the IPSSM, what we talked about, I do think a lot of transplant centers, are considering transplanting patients with higher risk IPSSM. And obviously Mateo's data supports that idea. I'm in favor of doing that. I know other centers that we refer patients to sometimes, still are only transplanting patients that are IPSSR, high risk. But I think in the long run, we're sort of moving away from that. And I think, AI is, because running transplant studies and randomized transplant studies is just in general unrealistic. And I think transplants, as everyone knows on this, webinar, running transplants is getting better and better, and immune suppression is better, GVHD risk is lower, and so ultimately, I think we're transplanting more patients, and I think people that do have high risk molecular mutations, are going to benefit from transplant, and so I think that's where that is moving currently.
I'd just like to add that with regards to transplant, as I mentioned, the comorbidities are a huge factor to consider. We as physicians, we usually like objective things such as positive mutation, negative mutation. Is it there? Is it not there? Is it high risk? Is it low risk? These are all things that helps us clinically, but in general, the patient is a patient as a whole. I know I have a colleague who I met with her in London, Ontario. She trained in Dana-Farber. She used to tell me they used to transplant GATA2 mutated patients. Just GATA2. That's they don't even have MDS or anything else, but they just kind of, for example, detected it on like testing for becoming donors or whatnot. So the answer to that is really complex. There's no straightforward way, and it's all these language models. I really congratulate you guys for making our life easier and incorporating these models in our day-to-day life. But in the end of the story, the hospital setting, even like the HIPAA filters, if they're there or not, these are all things that really play a role in deciding when to transplant or not. But yeah, the molecular things, as much as we like to put much weight on it, it's still one of the factors that we're considering in transplanting patients.
Agree. And I think that's why we, again, echo that, the reality is that these are decision support tools that, we're talking about, things like up-to-date NCCN guidelines that you would reference, but the clinician is the one that's ultimately making the decision at the end of the day.
And one of the things that I used to give in my talk, all models are wrong, but some are useful. So that's why I always operate on those models. To your point, I mean, you can get somebody that it looks like and smell like a lower risk and or high risk, but you know that this patient is not going to do well with the transplant, so it's not like, or they don't have donor, or they are like 70, like 69 borderline, so there are so many variables to that. And one thing, by the way, which is interesting part, will AI take your job as a physician? And the one thing that we don't have good in AI today, with all these models, is judgment. So these models can reason, can understand. In fact, they are better than us as a human in gathering data, putting data together. We can't compete there. But in terms of judgment, they lack the judgment. And that's what we can bring as physicians. That's what comes from experience, from dealing with the patients, seeing the patients. This is why I don't think, at least in the short term or even long term, that AI will take physician job, because exactly what you said, Omar, is not like, yeah, I calculate IPSSR, it's high. Okay, transplant, see you. It's not that easy. It's more complex decision making. Well, all right, Ahmad.
Yeah, I think we're on time. Great session, and that's probably the last session of the year. We are planning a session to summarize all the AI data in ASH. So we'll see if we will be able to do that by end of December, or we'll do it early January. We'll try to finalize that in the next couple of weeks. But if not, we didn't meet you this by the end of 2025. So Happy New Year to everybody, and we'll meet you in January 2026. We are planning to continue this in the next year. We may expand it a little bit and try to include oncology in general, and maybe other subjects that may interest physicians in general, so not restricted only to clinical issues. But thank you very much. It talked by both speakers, Omar and David, and thank you, Aziz. Again, thank you to the SSBMT and to Bristol Myers Squibb for their sponsorship, and have a great evening, everybody.
Thank you, everyone.
Thank you.
Guys, have a wonderful evening.
You too.